We're going to talk about a little bit about focal therapy. It's kind of a whirlwind tour of what focal therapy is and some of the details around it. So I have no disclosures. We're going to go a little bit through the background, rationale, some of the modalities, and then we'll conclude. So there's been a lot of parallels made with breast cancer and prostate cancer, and it's kind of been across the board. And this is no different. This is from the seminal trial comparing mastectomy versus lumpectomy, showing no difference. And just getting to that point was a whole challenge in and of itself. And I encourage you to look at this book. It's called Breast Cancer Wars, that describes the entire process getting to this point. So what is focal therapy? So in its purest form, it's essentially targeted ablation of the tumor, but can we really be that good? So we'll discuss that. But focal therapy essentially has come to define anything that's a subtotal treatment of the prostate. So what's old is new. This is from Hugh Hampton Young from 1937. He said, "We have shown that in the early cases, a hemiprostatectomy may be sufficiently radical." So this is not a new concept. So where were we? Back in the day, we were doing a significant amount of treatment for patients. And so this is from the PICO study, basically. Patients who had Gleason of 2 to 4 were the majority of the patients being treated. Now, this is not Gleason pattern. This is Gleason total. So significant overtreatment. We definitely have course corrected over the years. This is from Dr. Cooperberg and the Aqua study, showing that active surveillance is continuously being taken up over the years. So there's been a course correction. So where does focal therapy fit in? So potentially it's an intermediate approach where we can improve functional outcomes without sacrificing oncologic control afforded by whole gland therapy. And potentially there is a space there where we can fit in focal therapy. So what's the rationale for focal therapy, and how do we do this successfully? So we'll talk about the index lesion concept, advances in imaging and staging. There's MRI, PSMA, some new AI technologies, and it's been successful in other organs such as breast cancer. So the advantages, potentially cancer control versus cure, avoid and delay whole gland treatment for patients really interested in maintaining functional outcomes. There's less side effects, can be retreated, and potentially can receive definitive therapy afterwards. Disadvantages, long-term outcomes are unknown as of yet. Ideal tumor patient selection can still be challenging. Recurrence is really not well defined, specifically biochemical recurrence. Optimal salvage strategies are unclear, and cost remains to be worked out. So prostate cancer is inherently a multifocal disease. However, there's a significant proportion of patients who have unifocal disease. So looking at the index lesion, so what is defined generally as the largest, highest grade tumor with extraprostatic extension. And most of the time, the grade and stage is determined by the index lesion, as shown by this study, where the vast majority of patients, for example, in PT2, the highest grade and biggest tumor was the most important, similarly with higher stage disease. Similarly, this study basically kind of was as a review looking at the index lesion, where they showed that the index lesion itself showed hallmarks of cancer, whereas the low grades, low volume secondary lesions did not. Can we reliably identify the index lesion? So MRI has been very powerful in this space. It preferentially detects high-grade lesions, specifically for grade group 2, and there's good concordance, improved detection of the anterior zone, and extraprostatic extension. But there are limitations. This study we did with Dr. Reiter, basically showing that there are some limitations where MRI can miss about 10 to 25% of non-index lesions and can underestimate volume as well. And it's obviously heavily dependent on expertise. And so as you can see, there is some grade group 8 and above that were missed, and large tumors that were missed as well. Can PSMA help? So this is a study where they looked at 138 patients who underwent prostatectomy who were potentially eligible for focal therapy. And on final pathology, they showed that 33% of those patients were not suitable for hemiablation. When you add when you add PSMA to it, you decrease the poor selection by about 57%, and it only had about 3% false positive rate. And this is an example where there's discordance. As you can see on the PSMA, showed contralateral lesion that was not picked up by MRI. So this leaves us with this criteria for patient selection: PSA of less than 10, grade group 3 and lower, unilateral single tumor. You can have contralateral grade group 1, MRI visible lesion, and targeted biopsy plus a 12-core biopsy. And this is based on the UC squared consensus, which I thought kind of articulated this the best, and I encourage you to look at this in more detail. What are the foundations of a good focal therapy program? Really, radiology is a big part of it. Optimized imaging, expert radiologist, and of course, urology, the ability to do fusion biopsy. Picking the right modalities. Certain modalities are a little bit more flexible and versatile than others. One question is, do you choose one and you really run with it, or you choose a couple? There are some nuances to choose one over the other. So generally about a couple would really help in the armamentarium. And of course, closing the loop, having a focal therapy working group where case and imaging review and constant quality improvement. So I'm not going to go into a lot of detail of the focal therapy modalities, but just to kind of introduce the subject and give some data. So these are the modalities that are very most common: cryo, HIFU, focal laser ablation, IRE, which is electrical energy, and photodynamic therapy. This is just a little bit of a summary of the HIFU data, and to summarize it here, about 65 to 95% absence of clinically significant cancer on the follow-up biopsy 1 year in the treated region. Very good continence rate, very good potency rates, and salvage treatment low. It was generally low at 1 to 2 years. This is an important study. It's a phase 2 study, a single arm, looked at unilateral MRI visible lesions, and this is an in-bore HIFU treatment, and the primary outcome was grade group 2 free rate at 24 months. And they basically showed that the treatment actually worked very well, with 88% negative biopsy in the targeted area. However, in the whole gland, there were some cancers, and of course, importantly, there were some high-grade recurrences in the whole gland, but it looked very well actually in the treated area. Some cryotherapy outcomes. This is focal cryotherapy, and generally very similar. The biopsy rates are generally very high, especially in the infield, and similarly with functional outcomes. Irreversible electroporation. So this is technically a non-thermal ablative technique, although there is a little bit of a thermal component to it. It's pulses of direct current electricity induce it and produces irreversible pores that ruptures the cancer cells, leading to apoptosis. This is one of the bigger studies, a retrospective, 229 patients from Australia with median age 68, PSA 5.9, and 20% contralateral grade group 1. And some of the results: infield recurrence rate is generally very low, 7%, and this is at the 1 year mark. And out-of-field disease, only about 16%. And salvage treatment was generally low at that point. Of course, again, quality of life outcomes were significantly high, meaning that there was very low urinary score. Over the follow-up period, there was a decrease in sexual function, but remained relatively okay. And of course, bowel and others were all okay. For the sake of being provocative, this and promote some discussion. So this is a study that basically asks, what are the biopsy positive rates in patients who underwent radiation and at the 2 year mark? And surprisingly, there is a high percentage of positive biopsies, and this is a relatively contemporary treatment cohort. Where you see the weighted average of about 32% of patients had positive biopsy 2 years after radiation, and we'll just leave it at that. So word on follow-up: generally patients 6 months are followed every 6 months, and then annually. The imaging can be pretty tricky to interpret, and there are some newer guidelines in terms of how to interpret and how to score some of these post-treatment findings. PSAs followed regularly, and biopsies, obviously, our main outcome and functional outcomes review very regularly. So in conclusion, if the index lesion driving biology could be reliably identified, oncologic control of the cancer could be achieved while maintaining quality of life. Evidence base is growing. There's acceptable short and potentially intermediate term outcomes. Of course, excellent functional outcomes. Patient selection is critical. And we'll address this more in the next talk about clinical trials that are ongoing. Thank you.